You're listening to Pedia Pain Focus, episode number 21. Today, we talk about what it means to prescribe medications for off-label use, whether you should be doing that, and when you do, how to do it safely, minimizing the harm to your patients and the liability risk for yourself. So, stay tuned.
Pedia Pain Focus.
You're listening to Pedia Pain Focus, brought to you by Proactive Pain Solutions. Pedia Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hi there. Thank you for joining me in Pedia Pain Focus. I'm your host, Dr. Anjana Kundu. Let me ask you, do you ever prescribe Tylenol or paracetamol for migraine or arthritis or for patients under 2 years of age? Did you know that you were prescribing an off-label medication when you did this? If you're thinking or saying, what? Tylenol can't be off-label. Heck, we don't even need to prescribe it. Patients can just get it themselves. Believe me, you're not alone. Acetaminophen or Tylenol is FDA approved to treat mild to moderate pain and fever. For example, when you treat a mild headache, backache, toothache, muscle aches, sprains, that's approved. However, when you're telling your patients to use it or prescribing it for arthritis or migraine and even more severe pain like dysmenorrhea, you, my friend, are using that off-label. And if you're thinking, of course I knew that, duh. Now I'm curious. If you knew that, what kind of counseling or discussion are you having with your patients when you're using your medications in this particular way? Now, you can let me know that in the comments in this podcast. This episode isn't simply about Tylenol or even about me pointing out that what you thought was the right thing to do for your patients is not appropriate. Nothing like that, my friend. Today's episode instead is about a very pertinent discussion about whether and how to navigate the clinical dilemmas we as physicians, nurse practitioners, or any clinician with a prescriptive authority face when we're treating patients with conditions for which there are limited or no FDA-approved treatment options. Why? Because there are 3 reasons. First, it raises questions about when or whether it's appropriate to prescribe medications for off-label use or indications. Second, what might be the ethical or legal implications for doing that? And finally, how do we navigate these dilemmas to ensure that our patients get the needed treatment safely and that we achieve it ethically and with minimal liability risk for ourselves? As you know, the current COVID-19 pandemic has posed many challenges beyond the total shutdown of our lives that we've faced, and we know that a lot of it has to do with the facts that we're still discovering new information about the virus, about the illnesses that it causes, and the treatment options. I'm sure you've all read or seen or heard about the off-label use of various treatment options for COVID-19, including the infamous hydroxychloroquine. But we're not really talking about that today. Yet, it does highlight the fact that all of us who are treating pain, especially those of us who are treating pediatric pain, we are frequently faced with limited evidence and limited treatment options with appropriate labeling by the FDA, and thus we have to contend with off-label use of many of the medications for our patients. And if you think that this is unique to pain physician, it's not. Off-label medication use is fairly prevalent across all medical disciplines, some, of course, more than others. In general, 1 in 5 prescriptions, that's 20% of all prescriptions, are for off-label use of medications. But it's more common, like I said, in some conditions. For example, certain patient populations like pregnancy, lactation, and pediatrics. And even within pediatrics, it's even more so for preterm, term infants and neonates or anybody under 2 years of age. Up to 90% of medications in pediatrics can be off-label depending on the condition that's being treated, the age of the patient, even the medication, or the clinical setting that it's being used in, whether it's an ICU or pain management. It's also more common for rare or life-threatening conditions like oncology. About 80% of oncologists report off-label use of either their chemotherapy and or other symptom management medications like Benadryl or the diphenhydramine or even benzos like lorazepam that they commonly use for treatment of intractable nausea, vomiting, where the other approved medications have not been effective enough, or during conditions for which there are limited or no FDA-approved alternatives. And this one, my friend, has pediatric pain conditions written all over it. Take any of the pediatric pain condition, and that will fulfill this requirement. So for pain, for example, the tricyclic antidepressants, SSRIs, or the selective norepinephrine reuptake inhibitors, or the SNRIs, like Cymbalta and duloxetine, or even the gabapentinoids. They are being used for chronic pain and neuropathic pain without the FDA approval for these conditions in pediatrics. Similarly, we're using beta blockers for migraines and Clonidine for autism spectrum disorder and sleep issues. Now, before we dive into whether it's appropriate to use medications off-label, let's take a quick look at what it means to have the labeling. What does it mean to be on-label or off-label? Now, labeling means that the FDA has evaluated the clinical and scientific data submitted by the company, and they have determined that the medication is safe and effective for a certain disease or for certain age group in a particular dosage. Now, safety doesn't mean that that medication doesn't have side effects. It simply means that the benefits of using the drug for a particular use outweigh the potential risks. The FDA labeling in this regard, it offers some guidance on the following. Number one, how to use the medication safely and effectively for that particular use, like the specific disease, the age, and dosages. And it provides information about the risks of the disease and the information that we as healthcare professionals should be discussing with our patients before our patients take that medication. So anytime a medication is being used outside of these parameters that the FDA has determined, then it's called off-label medication use. That means it could be a few different situations. Number one, when a medication is used for a disease or medical condition that it is not approved to treat. For example, when a tricyclic antidepressant like amitriptyline or nortriptyline, which is approved by the FDA as an antidepressant, so for treatment of depression, but when we're using this for treatment of neuropathic pain or headaches, then that is an off-label use of that medication. Number two, when a medication is being administered in a different way. For example, a medication is approved for use as a capsule, but it is instead being given in an oral solution form because your patient can't take capsules, or when it's being used topically instead of the capsule. And sometimes, for refractory and localized neuropathic pain, I may have a ketamine with or without lidocaine cream or topical application, and I often get it compounded. So that certainly is an off-label use of ketamine and even lidocaine for that matter. And sometimes for my palliative care patients, when they're at their end-of-life issues, they have dyspnea, they've got pain, and may have very limited IV access or limited ability to take medication orally or any other route, I may use a nebulized form of opioids or benzodiazepines to treat their pain and their dyspnea. That, again, is a off-label use of medications. Another situation where we're using a medication in a different dosage, for example, Cymbalta or duloxetine, which is approved for chronic musculoskeletal pain in a dosage of 60 milligrams per day. But instead, I choose to give my patient 30 milligrams twice a day because they're tolerating that better. So that technically is also off-label use. And number 4, it may be when a medication is being given to a different population than what it has been approved for in the FDA labeling. For example, the use of pregabalin or Lyrica for postherpetic neuralgia or neuropathic pain or fibromyalgia, but in pediatrics. We know that it's been approved in adults, but when we use it in pediatrics, that's an off-label use of the medication. So what are the common reasons for this off-label medication use? Let's take a look at those as well. Number 1, that there may not have been any studies in a particular population. For example, we just talked about pediatrics. We also had that example when I asked you whether you were using in children under 2 years of age, because Tylenol has not been studied sufficiently for under 2 years of age. Number 2 would be where medication has not been studied for this particular use, but it has shown results in other similar conditions. An example here would be gabapentin for postherpetic neuralgia, but when you choose to use it for other neuropathic pain like complex regional pain syndrome, that it has not actually been studied, but it makes sense to use it that way to you and in literature as well. Number 3, that this particular medication has not been studied yet, but other medications that are related to it or are in the same class have been successfully used and studied and treated and labeled that condition that your patient has. And an example here would be, for example, Savella or milnacipran, which is an SNRI similar to duloxetine or Cymbalta, but that has not been approved and studied for use in diabetic peripheral neuropathy or the chronic musculoskeletal pain. Number 4 would be that there is no approved drug to treat a disease or a medical condition yet. And for this one, just take your pick. Any pediatric pain condition would be a prime example here. So I don't really need to elaborate this one. Number 5, that there are all the other approved treatments that you've tried and they have not offered the benefits that your patient needs, or they are not tolerating that medication. An example here I would give you is my teenager patient who had motor vehicle accident, had a C-spine injury, developed a quadriplegia, and also right upper extremity intractable neuropathic pain. And that pain would respond initially to some of the treatments. We had maximized all the medications for neuropathic pain. Now, mind you, it was a pediatric patient, so obviously we were already using off-label medications. But even within the normal gabapentins, the tricyclic antidepressants, pregabalin, none of those were tolerated by my patient. She was having memory issues or too somnolent, or she was having adhesive allergies. And finally, we ended up using Lamictal or lamotrigine for her, and she did benefit from that. So here's another example. Number 6 is that this medication has been tried for a disease or condition closely related to that which the drug is approved for. And this may allow our patient to potentially benefit without having to wait for the FDA approval for their condition. And here, the example would be using gabapentin or pregabalin for complex regional pain syndrome or for a metabolic neuropathy, because we know there are some other neuropathic pain that it has been approved and beneficial for. Similarly, we often use Clonidine, which is an antihypertensive agent for opioid or benzodiazepine withdrawal or weaning, because it provides sympathetic downregulation. So as you can see, in situations like this, you can talk to your patients about using an approved medication for an unapproved use in order to treat their medical condition. The truth is that once a drug is FDA approved for a specific indication, legally, a physician can use it for any indication. How you go about that is what's important. And more on that one in just a little bit. But first, I thought I should quickly review the reasons why labeling or relabeling may not occur. Now, there are 3 reasons for why this may not occur. Number 1, because often the advances in clinical medical practice will outpace the FDA's ability to approve new drugs or to relabel a previously approved drug with a new indication. Now, did you know that it takes 6 to 8 years and $1.7 billion for a new approval? Is anybody surprised by that? Raise your virtual hand if you are. Well, I have mine up because I was surprised by those figures when I first learned them. I mean, I knew that the FDA approval process was quite involved, quite extensive, expensive, and it takes a long time. But this much? And these figures were definitely a surprise to me. No wonder only 40 to 60% of submitted drugs get FDA approval. So what the FDA has been doing during the pandemic is quite remarkable. And even though it's remarkable on one hand, we should also be cautious that the expedited approvals may not have had enough information to thoroughly vet the safety and efficacy profile of the drugs or vaccines or whatever they are approving currently at an expedited pace. Now on to reason number 2. That is lack of financial incentives for the pharmaceutical companies for relabeling of drugs once they've already been approved by the FDA for one indication. Any additional revenue that this company may be able to generate is not enough to offset the expenses that they will have for additional trials that are needed for relabeling. So pharmaceutical companies really don't have any financial incentives, and we know that our whole system is really governed by what's beneficial and lucrative to pharmaceutical companies. Okay, I know I'm being a little sarcastic here, but that's a real contributing reason to why we end up having to use medications off-label. And the reason number 3 is that there may be limited evidence of effectiveness of the on-label use in certain patient populations. And I've really been saying this repeatedly, especially as it relates to children or pregnant women or elderly or even those with psychiatric patients. For children in particular, there are some unique scientific and or developmental, ethical, clinical, like there are not enough numbers, and logistic considerations that have to be taken into account. And of course, the lack of financial incentives when you can get it approved for adults with enough numbers and quickly get it done. Why would the pharmaceutical company waste their time in trying to get the pediatric populations enrolled? Now, all these will then, of course, amount to a non-priority on pediatric labeling, right? Although I've said that, there are federal laws like the Best Pharmaceuticals for Children's Act from 2002 and the Pediatric Research Equity Act from 2003, and finally the 2012 FDA Safety and Innovation Act. They have substantially increased and incentivized the clinical evaluation and expanded use labeling of drugs in children. And still, as I said, we're even now having up to 90% of medication in pediatrics being used off-label. These laws and regulations allow the FDA to require pediatric studies earlier in the drug development, but that doesn't necessarily mean that they can't have approval for adults prior to getting pediatrics in. So you might be thinking, what should a prescribing physician or any clinician who has prescriptive authority do then? Should you even bother? Should you be prescribing medications for off-label use if there is insufficient data for labeling, when you could be held liable for harm or adverse outcomes if they were to come? Now, these are number 1 and number 2 of the dilemmas I had mentioned at the beginning of the episode, and we are facing these every day as prescribers. So let's see if we can answer those. The answer, my friend, is yes, and absolutely, as long as you follow a reasonable approach to use of off-label medication guided by good faith, in the best interest of the patient, and without fraudulent intent, and finally, guided by best available evidence. Remember, the FDA regulates drugs approval labeling, but not the drug prescribing. That lies in your hands, you as the experts. Once the FDA approves a drug, healthcare providers can generally prescribe the drug for an unapproved use if they deem that it is medically appropriate for their patient. Now, granted that when a medication is used in a different way or a different route, then it can change its efficacy and safety profile of that medication. And theoretically, it may increase the liability risk for a practitioner should there be an adverse event or a poor outcome. Then again, a practitioner may be held accountable for the negligent use of any drug in a civil action, regardless of whether the FDA has approved the use of that drug or not. As long as your decision was made based on the best available evidence at that moment and in good faith and in the best interest of your patient and without fraudulent intent, that risk is minimal. So this should not dissuade you from prescribing your patients the needed therapies as long as you're doing it the right way. Because if you waited for pediatric labeling of the medication to come around and didn't treat your patient, then you would have very little to work with for your pediatric patients. And those children will lose out. And if those children, your patients, lose out, so will you. Now, another reason you should be prescribing, regardless of the on-label or off-label stature, is that though the FDA approval is based on available evidence of safety and efficacy of a drug for a specific indication, it does not guarantee either one of those, even for the ones that they approve labeling for. For example, the FDA had approved drugs like the Vioxx, which is a COX-2 inhibitor and anti-inflammatory, that was recalled in 2004 based on evidence of increased cardiovascular risk and increased risk for stroke, which only became apparent after it had been in widespread use in the late 90s to early 2000s. So they pulled it off. They issued warning and changed the labeling altogether. So ultimately, it really falls on the physicians to determine whether that's appropriate for their patients or not, and this is where your expertise come into play. And moreover, the off-label is not synonymous with off-evidence, and it doesn't imply an improper, illegal, contraindicated, or investigational use. So even case reports of smaller clinical trials or even retrospective review studies, etc., are all evidence to help support your decision-making. Now, they may not be the top-tier evidence as deemed by the scientific hierarchy, where the double-blinded randomized controlled trial is the king and everything else comes later, but it's still valid scientific evidence nonetheless. And it's more than sufficient to make a valid expert opinion about a medical appropriateness of a therapeutic agent. That depends on you and your judgment. For example, I'll give you some examples. Propofol is being used increasingly for intractable migraines, intractable chronic daily headaches, and propofol is an anesthetic, as you all know, but it's being used for pain management in certain dosages. It's obviously not approved by the FDA for that. Similarly, lidocaine infusions have been used increasingly for perioperative pain or acute pain, chronic pain, and has been used for decades now clinically. As a matter of fact, I was using lidocaine infusions for our pediatric patients with neuropathic pain, headaches, and even for our sickle cell patients since 2004 and 2005, before there were enough clinical trials, and certainly before the evidence-based guidelines that have been put out by the ASRA around its use now for pain. And our retrospective study is one of the earlier evidences out there for the use of lidocaine in pediatric chronic pain management. And I'll include these resources in the show notes if you're interested. The bottom line basically is, as long as you have a reasonable approach to off-label medication use, and that reasonable approach is then guided by, I will say it again, good faith in the best interest of the patient, without fraudulent intent, and guided by best available evidence at the moment. Even if that evidence is a single case report, you can and you should go ahead and use a medication for your patient's benefit. But be sure that your patient and family understands the implications and that they agree to proceed with trying it. Now that brings me to the last and the most important element of this episode. Now that all this wasn't important, but now putting all this into practice is where this comes down to. It's navigating the moral, ethical, and liability dilemma when you're prescribing medications for off-label use, which means what we're going to talk about right now is dealing with how do you ensure that your patients get the needed treatment safely and that we can achieve that ethically and with minimal liability risk for ourselves. Now, I divide that into 5 sections and pay attention in case you are off doing something else, multitasking, come back to me because this is going to be really important for you. Number 1, weighing the evidence, which basically falls on you. So you need to consider the following when you weigh the evidence for off-label medication use. Is your decision-making guided by the best available evidence? So have you evaluated the evidence? And if so, what kind of scientific data or evidence is that? How strong is that evidence? Again, it doesn't matter. Even if it's a single case report, that's okay. As long as it's there, as long as you can justify. Now, do the benefits for your patient in this condition outweigh the potential risks? Now, this can be a little bit tricky, especially when there are multiple comorbidities, but that's where your expertise and your clinical judgment come into play, my friend. You are the one who's evaluating this evidence. Off-label use is an FDA regulatory term that doesn't denote anything about clinical risks or benefits. That is for you to determine as an expert. Element number 2, step number 2, therapeutic decision-making. Now, what you need to determine is that this is in the best interest of your patient, right? So what would you look at? Are there other medications, drugs, therapies that are approved to treat your patient's condition that you may have overlooked? So you want to just make sure that you haven't overlooked something already that's out there and approved. If you've done that, then move on. How likely is it that this drug will work better to treat your patient's medical condition than using the already approved treatment, if there are? If you've already looked at that as well, what are the potential benefits and risks of using this particular medication? Of course, earlier we evaluated whether it was appropriate, and now you're actually thinking of what the potential benefits of risk of using this patient in practicality in your patient's life would be. Next is, will their health insurance cover the cost of this medication, which could also fall into the area of potential risk and benefit for your patient, right? If it's going to be an undue financial burden, then that might be a big risk and your patient may not even want to take it. So consider that as well. And if it is going to be a big risk and the insurance company can't cover it, then you may want to look at some alternatives, like maybe there is a clinical trial that's going on and this patient can enroll in that. Or there may be a medication assistance program that you can guide your patient to pursue, either through their insurance company or the pharmaceutical company or any other avenues. And you can encourage those patients to explore those avenues. And that all fall into the therapeutic decision-making. Step number 3, shared decision-making. So now you move on to make sure that you're involving your patient. As a tenet for patient-centered care, patients and families need to experience treatment decisions as a collaborative and shared process with their clinician, right? So with you. And what does that mean? What you have to think about is, does your patient understand the implications? And if they don't, have you made sure that they do understand these? Do they understand the goals of treatment? And are those goals of treatment that you hold, are they congruent with the goals of treatment that your patient or their family holds? Unless they're incongruence, this is not going to work out. You need to also make sure that your patient understands that this medication is not experimental. They're not guinea pigs. And if it is experimental, that's okay too. In which case, you just need to make sure that you have informed consent. And I would actually venture out to say that you should have informed consent no matter what, because you're using a medication in a non-labeled way. Now, you need to disclose to your patient if and what choices they may have with or without this medication. You need to disclose and discuss with your patient any particular risk-benefit ratios which are consistent with your standard of care, I hope, and make sure that your patient knows that you are deviating from what is exactly known about the patient, because the side effect profile that's listed is based on the FDA labeling. And when you're changing the dosage or frequency or the way you're applying or for the population that you're changing it for, it may actually change the outcomes. It may change the safety and efficacy profile. And for that reason, it is really imperative that you reassure your patients how you would be monitoring, and then you give them clear directions and instructions on what they should be looking for themselves when they're taking this medication in this different format. And finally, you identify and address any barriers that your patient may have to taking this medication, whether it's expense related, whether it's scheduling related, because their school is very strict about administration of medication. Anything that impacts their ability to take the medication should be considered. Step number 4 is discussion and counseling. Some of the elements I've already talked about that you should discuss and disclose to them. But really, here are some of the points of discussion and counseling. If and when these patients choose to proceed, provide them with clear instructions on what dose, what regimen, what duration, what the side effects of the medication they can expect, what precautions they need to take, any interactions that they need to know about. You should counsel them around what they should do if the side effects were to occur. You should also tell them what expected time frame is for therapeutic benefits. When should they see any benefit from their medication? And what is your expected course of therapy? What would be the indicators that the medication is working? And how they can evaluate the benefits by themselves. Another thing you're going to do is you're going to give them a clear plan on monitoring and follow-up, whether you want to follow up in outpatient or if they're inpatient and you're implementing this inpatient in hospital setting, how often you would be seeing them and evaluating. Finally, we talked about the expense of treatment in a few different ways. Obviously, you need to discuss that in real terms with them, give them other alternatives, thoughts, directions, if their insurance company isn't going to cover. Obviously, you should be discussing this using a language that a family and patient can understand, which means using an interpreter if it's English or if that language is their second language. It means using a language without jargon. It means using a simple 5th grade education level language, which is what is consistent with most of the scientific research and directions. And finally, and ensure that they're understanding all this. So obviously, besides the language issue, make sure that you can ask them to repeat what their understanding is and invite some questions. This will help with a productive discussion and decision making. And this will improve patient engagement as well. And final and 5th step is documentation. Of course, where would we be if there was no documentation, right? Okay, jokes apart. Documentation not only makes you accountable for being thorough and for following all the important elements, ensuring that you've done the right thing for your patient, but it also allows you to create a supportive evidence that this process was a shared decision-making made in partnership with your patients and families. In case there were any questions or liability issues that were raised later on, you can refer back to that this was a shared decision-making, that this was an agreement, and that you had discussed all the various elements, and that you had made this decision methodically and logically based on the evidence available to you. So be sure to document the elements of your discussion with the patient about the medication or even a procedure if you're using that, its risk, its benefit, alternatives, the patient and family participation in this decision-making, and their understanding and agreement to proceed with this plan. Make sense? All right. So there you have it. This wraps up the discussion on off-label medication use. I hope I have given you a step-by-step approach to evaluating whether you should consider an off-label medication use for your patient's condition. And actually, I pretty much said that if you are doing pediatric pain management, it's really not a question of whether, it's a question about when. And when you do, I hope you will use this 5-step framework that I just provided for you. Now, I would love to hear from you, so please leave me your comments or your questions or any suggestions you may have. And if you can, please take a moment to provide a review of this podcast. This will not only help me, us, more importantly, what it'll do is it will get this podcast out there for those who may actually need it and benefit from this information. So a great big thank you from me and also on behalf of all those people that will use it and that will see it because you chose to do a review for us. Thank you. Oh, and one more thing. Please don't forget to subscribe if you haven't already. And I will be back with you in 2 weeks with another great episode. Well, I always intend to have great episodes, right? But until then, stay safe out there and be proactive. Bye now. Pedia Pain Focus is brought to you by Proactive Pain Solutions, a company committed to improving the access, quality, and expertise in pediatric pain care. Through our online education and consultation for clinicians and institutions, we're transforming pediatric pain medicine. We're creating experts and leaders in the field and empowering patients and families with knowledge and tools for self-management to live a functional life. If you wish to advance your pain care expertise or improve the operational performance of your pain care services, please give us a call at www.proactivepainsolutions.com.